Okay, I'm going to get things rolling here. First, I want to welcome, everybody here. This is an NRBS sponsored series. Today it's Sadar Psychological that will be represented by Dr. Linda Walker, who I will introduce here shortly. But before that, I just wanted to put in a plug for people to, if you are not a member of, NRBS, we would urge you to consider it. The cost of that is $150 a year. You can visit our website to see the benefits. But we are attempting to do a lot of things for our field. One of the things that I want to point out, we are doing what we call Connect Tuesdays, and this year, 2025, we are devoting it to topics that are aimed at finding a way to unify and to advocate for biofeedback, neurofeedback. And I just either we are going to send out an email about that or it's gone out. But I really urge anyone who has a real interest in the future of our field to attend those meetings. They're the first Tuesday of each month. And anyway, enough about that. The other thing that I want to mention, be on the lookout for news about our yearly conference. It will be in the fall. It'll be the weekend of October 24th in New York City. We are very enthused about being there and about some of the preliminary people we are lining up. So just keep that in mind and be on the lookout for it. Okay, and I think Ronnie will be putting in the uh, the chat, the website for NRBS and the website for Sadar Psychological, because we do offer Alpha-Theta courses. One of them is an online course. The other we do about once a year, and it's an in person over the weekend practicum, and you can find things about that at the Sadar Psychological website. Okay, so it is my pleasure to introduce Linda Walker. I could talk for a long while about everything she has accomplished, everything she is involved in. She is one of the most knowledgeable people that I know. And when I say knowledgeable, it's about clinical skills. It's also about hardware. It's also about software. She also is a great teacher. I find it my honor and my privilege to have her as a colleague, but also a friend. And I want you all to hear from her. So I will just just turn it over to Linda. Thank you, Linda.
Thanks, Mitch. I appreciate that. Let me bring up my presentation here. Let's see. Everyone seeing that okay?
Yes.
All right. So today I'm going to spend some time talking about alpha-theta neurotherapy and really talk a little bit about if you are thinking about integrating it into your practice, the considerations that you might want to have as you go about that. I I'm going to talk till about 10 minutes too. And then I'm going to stop and open up for questions. But Mitch is going to flag me if need be, if there's something that kind of comes up as I'm going into this discussion. Uh, I guess, first of all, I would say cramming alpha theta neurotherapy into an hour discussion is not terribly realistic. There are a lot of moving parts, but what I hope to do is give you kind of a flyby overview, unpack a little bit about, well, what is this really? How can I apply it? What it might look like, just generally speaking. Um, we need to talk about outcomes. Those are so amazingly impressive. And that one's for Saul, by the way. And also the key ingredients that go into alpha theta neurotherapy. And then finally, what is it that you need if you're considering integrating that into your practice? So this is kind of what we're going to jump into. A very brief history about how I got into it, because I think it's helpful to kind of know what that path has been. Uh, 25 years ago, I started working with Bureau of Juvenile Justice for the state of Michigan, and I was, my background was community mental health, behavioral health. Um, Coming into working with young people, adolescents who had really had every single therapy in the book that you could possibly think of. And we got a grant, a substance abuse grant, to implement neurofeedback. Well, over the time and years, it we did traditional neurofeedback, we did biofeedback, we did alpha theta neurotherapy, and we evolved a program. For the alpha theta neurotherapy piece of it, we integrated that in a larger recovery setting. So these kids were getting 12-step recovery or what culturally appropriate recovery. We have a lot of Native young people here, and so Red Road was prominent as well in some of those discussion points and some women's-based recovery. So outside of alpha theta neurotherapy, we had kind of a wraparound program. Um, Flash forward, these are kids that had trauma, they had substance use issues, all kinds of learning issues and attention problems. Flash forward, after my work with Nokomis, I moved out into private practice. That was during the economic downturn when sadly the agency was closed because of economics. Uh, I started using alpha theta neurotherapy not only with individuals who had substance use issues or trauma, but also people who were seeking to optimize performance, people who had chronic illnesses, people who had anxiety or sympathetic disturbances. So it really kind of, my practice evolved outward as well. So I hope to share with you a little bit of what I've learned, and hopefully we can have a discussion about that. So let's start by, what is it? Alpha theta neurotherapy. I tried to keep this into this as few words as possible because it's really easy to start stacking them on. So I think these are the probably the 2 points that if I had to separate them out, alpha theta neurotherapy is teaching a client or a trainee, depending on your therapeutic background, a skill set that helps them learn to become deeply relaxed and create a pathway to access deeper or altered brain states. We utilize the EEG via neurotherapy to signal the depth of the state and shape the quality of that state. So it's bringing together a couple of things. Neurofeedback, there's the technical end, but there's a very heavy emphasis on what the client and trainee do along with the therapist together. The applications are immense, and I'm not even covering the iceberg here, the tip of the iceberg, but we tend to have, in terms of applications, things that are aimed at creating healing, insight, creativity, resolution, and well-being. So within therapy, people who come with any combination of those goals can benefit from alpha-theta neurotherapy. That would include addictions. The original work was in alcoholism, but we've since had a fair bit of work in just polysubstance use as well. Post-traumatic stress disorder, any condition, and I kind of lump these together a little bit, but any condition that creates sympathetic distress or overdrive, obviously PTSD does, but also things such as anxiety or stress management or chronic conditions that are aggravated by stress. So again, I discussed working with people with chronic illness. Anytime you have a chronic illness, whether it's pain or otherwise, it's going to be aggravated by stress. If we modulate the stress, if we teach people to ride above that distress into a different space, we can be very helpful to them. Optimal performance. Okay, so who isn't trying to increase or optimize their performance? Let's face it, if people are coming for depression, if people are coming for PTSD or addiction, if people are coming to pass the GRE, every single individual in that group is seeking in some way to optimize themselves. And so, from a broad base, alpha theta neurotherapy can be very applicable to many individuals. When we think about optimal performance, we think about learning. Sports isn't on here, but sports is a definite one. Meditation, creativity, performance in general. So let's kind of just stop really quickly, and we've talked about alpha theta neurotherapy, but there's a state involved here. And alpha theta neurotherapy is a little bit different than traditional neurofeedback. I want to teach people to access this state, but not necessarily live it. I mean, no one wants to ride down the highway with someone in a hypnagogic state. Not advised. But we want to teach people and give people the skill to access the state. And some really amazing things seem to happen when people learn how to move into this place. So the alpha theta state is what we would consider the border between wakefulness and sleep. It's not sleep. It's certainly not wide awake. Some people have described it as hypnagogic. It can be seen as intuitive, meditative. There's absolutely a transformative element to this. Tom Budzinski, I'm kind of a fan of Tom Budzinski. He's from Grand Rapids originally, by the way. Tom Budzinski developed what he called the twilight state, which had a lot in common with alpha theta neurotherapy. It's a reduction of your conscious defenses, and we become hypersuggestible. I think I had a typo there. I'll have to fix on that. And really, we're moving into a state where I talked about reduction of conscious defenses, but content with emotional charge that we experience in the waking state seems to really fall away in that dream state. So the content that really moved us emotionally, consciously, has less impact on us. It's a place to potentially work through some of that content in very, very careful ways. And interestingly enough, content that really wouldn't have had much of an impression on us in our waking state can have a great impression in that edge between border, between wakefulness and sleep. So it's a space where we can access things that, as a therapist doing cognitive behavioral therapy, I can't access. I've always liked to think about cognitive behavioral therapy as really trying to do therapy head on. I'm really talking to this frontal lobe here, but what we don't understand and what we seem to miss sometimes as therapists is that this frontal lobe is sometimes the last to get the message, and there's a whole lot happening in our subconscious, in our physiology that's processing this stuff before the frontal lobe could get a hold of it and deal with it. And I think the alpha theta state for me is one of those ways to take a little end run around the frontal lobe and access some of this, and then I can have a more healthy conversation with the frontal lobe. So, just from an EEG perspective, let's just have a quick look at what this looks like. I'm going to unpack the general progression of the neurofeedback process as we move on in this talk, but I think it's helpful just to kind of have a flyby. With that state that we experience, things are happening in our cortex. And this is an alpha theta session with an individual, and I'm just going to kind of talk you through this progression here. This is very first part of the session. This is the very first minute. This person has closed their eyes. We've done all of our prep work for our alpha theta neurotherapy session, and I am looking at their EEG. And what comes up? This person was a really robust alpha producer, lots of alpha. And I can see that in my displays below this EEG. So here's your alpha. It's that characteristic, kind of looks like mountainous morphology. And if I have a look at that, here's my alpha here. If I separate out this content that we're looking at, the squiggly lines, and separate it out into bands, alpha's the turquoise here, we can see that this individual is producing just over 25 microvolts of alpha with their eyes closed. They're producing a fair bit of theta as well, but alpha's dominant. And beta's a bit high, but relatively quiet. I can watch the trend of alpha as this session unfolds. Remember, alpha's the turquoise here, so we see the turquoise line as alpha waxes and wanes, which alpha does. It's not completely constant. We can see the packets of alpha as it rises in amplitude, and then again as it falls off. And it's clearly dominant over theta and beta here. Beta's the dark blue here that we can barely see, and theta's the purple. But something happens in this session as we move through. 10 minutes later, same person, this EEG looks rather different. I'm sort of seeing some alpha, but I'm also seeing a lot of other content work its way into the EEG as well. This individual has their eyes closed. What's happened to the alpha? Well, the alpha's gone from 25 microvolts to just over 5 microvolts. So it's really receded. In fact, the EEG in general, in terms of the voltage, has really quieted. We still have beta, it's receded, and theta certainly has receded as well. But at this intersection, we're starting to see some interesting things happen. I want to bring your attention to the line drawing down here below. We can see the turquoise alpha, which was dominant in this first one here, has started to kind of back off a bit. It still rears its head a bit, but theta's starting to compete with it. And as the alpha becomes quieter, the theta slowly starts to become a little bit more dominant until, and this is only a couple of minutes later, about a minute and a half or so, things look even different still. Visually, I can start to identify theta waves. So this is not a very good example, but what you've got here, thetas look, for those of you who had to be tortured with learning how to do cursive handwriting when they were a kid, theta looks like a cursive R. So you can see one right here. This is actually a slower theta wave too. It just has a lot of faster beta and possibly some gamma content writing right on the top of it. If we look at what's happening here in the EEG, theta is now actually the dominant player here. Alpha's receded. I mean, we've gone from over 25 microvolts to right about 5 microvolts. So it's really attenuated. The beta has too. It's become quieter as well. And what we notice here is now we get these packets of theta waxing and waning, kind of like the alpha was, except now we're deep down into that theta state. And these two states, the beginning state and even the deeper state, these are when special things are starting to happen in the EEG. Now, this is the first 10 minutes of a session. not unusual to see this kind of progression. Uh, we often see people who are starting to practice it and get the hang of it. It takes usually about 10 minutes for people to kind of shift down into that state. And then from there, my goal is going to be to help people access the state and stay in it for longer and longer periods of time. My actual alpha theta training time with actual neurofeedback going on the screen is around 30 minutes to an hour. And then depending on what the context is, uh, I always allow a good half hour for processing. So it's not just a neurotherapy session. And sometimes these sessions run a little bit longer than a standard therapy session. Again, depending on the context, depending on your parameters. In an ideal world, I would love 90 minutes to do this, but sometimes that doesn't work out for us. So I think it's important to understand that what we're dealing with here is something that's kind of old. It's not a necessarily new technology, although measuring this deep state with the EEG is certainly a newer technology. But the state we're accessing actually moves back to shamanic practices, to spiritual practices, to deep meditative practices. And we started using kind of our technology in about the 50s, 60s, 70s. Elmer and Alice Green, the Miniger Foundation in Topeka, Kansas, they were some of the first and some of the pioneers. And this is a picture, by the way, of Elmer Green. Oops, come back here. Getting ready to measure shaman as he moves into and begins to access deep states. So the Greens did a lot of research in consciousness, and they were some of the first that started developing biofeedback and EEG techniques for self-regulation and applying deep states work to students for brain brightening, for optimal performance. In the 70s, Tom Budzinski started developing the twilight state or twilight learning and working a lot with sleep and creativity and learning. And his work really uh, his work kind of took a little bit of a segue from Green and Green. There are some interesting parallels to alpha theta neurotherapy uh, and twilight learning, and there's some key differences as well. Uh, Tom utilized some repetitive messaging during his work and recordings, so we don't typically see that so much in alpha theta, but we could. Um, Flash forward even further, now things are getting kinda interesting. So, Peniston and Kokoski in the 1980s, late 1980s and into the 1990s, started working in addiction and PTSD, primarily with veterans. From there, we've evolved even beyond that. We've had some wonderful validations of Peniston and Kokoski's work, and in addition, we've started as a field to creatively build upon that methodology. And so these days, we might hear people talk about neuromeditation, and neuromeditation is an umbrella in which alpha theta fits nicely into. It also includes some other modalities, some of the alpha synchrony protocols, could also include neuromodulation. In addition, it could include even some Loretta modalities, or multi-lead feedback. So we've really evolved this, and we started building onto it. My talk and what I'm teaching with SADARs is the foundational piece of it, because I think it's important to understand where it came from, and then we can start to critically evaluate what we want to add to it as therapists and what makes sense for our practice and our participants. So before I start unpacking the what and the method of what this is, let's talk a little bit about some of the outcomes. Like, why would we want to do it? How important was this therapy? How important did it become? Peniston and Kolkowski in 1989 did a pilot study, and this pilot study was small. Granted, it's only 20 people, so in relative numbers, that's really small. But they utilized an interesting combination of techniques. Notice that we have neurofeedback in this list here. but it's right. Oops. Here we go. Neurofeedback is in this list, but it's right here. I think that this is kind of a key piece of Alpha-Theta as well. It's not only the state, but it's a multiple modality protocol. And Peniston and Kulkowski did a lot of things. They did some systematic desensitization. They used temperature biofeedback, guided imagery. They constructed visualizations. They did rhythmic breathing. They did autogenic training, and they did neurofeedback. So when we look at that list, we're seeing things that look a lot like neurofeedback, obviously, a lot that looks like biofeedback. We see some cognitive behavioral modalities. We see some narrative therapy integrated in here as well. So there's a lot going on in this protocol, and it's not just a single modality. It's actually a nicely crafted group of modalities. So their experimental group received what you see circled here in pink. The control group got 12-step programming. So, kind of your traditional AA programming. But something interesting happened. At 12 months after individuals had received this therapy, in the abstinence neurofeedback group, 79% were still sober. That's unheard of. It's unheard of in recovery circles. They also did some measurements in some other things. They looked at beta endorphin levels, which are kind of a measurement of stress, and found that there was a reduction in the neurofeedback group. And a year later, there was still a reduction in the neurofeedback group. There was also an improvement on some scales of the MMPI. I kind of fly by this one because there were possibly some design problems using the MMPI in some of these studies, but still it's interesting to note that some of the negative scales, schizophrenia behavior, things like that, improved. So people had less pathological showing on the MMPI. So that's pretty cool. 20 people, okay, that's interesting. But they didn't stop there. They went on, and in 91, just a few years later, they came back and worked with veterans again. And with this time, this was a group of combat veterans who had been experiencing PTSD and had been dealing with it for 12 to 15 years. And so these people had a lot of things they tried and not worked very well. Once again, they had an Alpha-Theta group, and they had a control group. They had a few more people this time. And the methods looked somewhat the same. We had autogenic training and rhythmic breathing. We had neurofeedback sessions. I want you to notice the intensity of these neurofeedback sessions. So they were 5 times a week. And it was, I think this was supposed to be 28 weeks and not 28 days. But regardless, they crammed in 30 neurofeedback sessions. They were also doing the behavioral work that we talked about in the previous study. So once again, we had some interesting results. These are interesting to me because it involves medications. And so every member of the neurofeedback group decreased psychotropics. So we had 15 people in the neurofeedback group. All 15 decreased psychotropics. The remainder were in the 14 were in the control group. Of those people in the control group, only 1 of them decreased meds, and 10 of them, most of them, increased medication and psychotropic. So they went the opposite direction. It gets more interesting to me even still. Only 3 in 15 people in that neurofeedback group reported a relapse of PTSD, versus 100% in the control group. That's amazing. Again, there were improvements in the negative MMPI scores, but there weren't those same improvements in the controls. And so part of the problem with the MMPI was possibly how it was administered, and it may have been administered in ways that we shouldn't validly compare it. However, it does say something that the control group doesn't see that change at all. That's interesting. So things are looking promising. And then we move forward into the 2000s, and we had a group out of UCLA. Bill Scott, David Kaiser, Siegfried Othmer was in that group. We had a bigger study. This is a big deal. They said, okay, well, we had some small control groups. Let's have 121 people in this study. And again, they're using alpha-theta neurotherapy. There's some variations to it. The therapy has evolved a bit. In addition to alpha-theta neurotherapy, this group thought, I wonder if we stabilized this group that we're going to work with SMR or beta neurotherapy before we did alpha-theta neurotherapy, if that would be helpful. And the other thing we'd like to do is we're going to inhibit delta, because I know when people start to move on that in that space between wakefulness and sleep, sometimes they go to sleep. And we want to keep them into this crossover threshold, not to delve too deeply into that sleep state, but let's see if we can keep people on the threshold. And so they also implemented a delta inhibit. This was a polysubstance use group. They were also receiving 12-step therapy. 12 months later, 77% abstinence in the neurofeedback group versus 44% in the control group. So third study, actually, there were several studies in the interim since the Peniston studies, but we're seeing these 70% numbers pop up a lot. And we're seeing it pop up in substance use issues, in PTSD issues, and that seems to be kind of consistent. And the neurofeedback group is blowing the doors off of the control group here. There was a 60% reduction in premature ending of therapy in the neurofeedback group. So we had people who were staying on in therapy. They were probably, in that case, not only benefiting from the neurofeedback, but they're benefiting from all of the other therapeutic modalities that you are integrating into this. And once again, we saw improvements on MMPI scores. That's exciting. So what goes into this therapy? Why? Why should it be special? It's more than just hooking someone up and selecting the right protocol in the software. We have, as therapists, to create a few things and help our clients create a few things. We have a context for the therapy. Why are we doing this? We have a real intention. It's not just to pay better attention, but we have an intention here. We're utilizing some things such as repetition. We're using imagery. We're using forms and aspects of creating a narrative and narrative therapy. We usually have some kind of transformative goal. We use symbolism, and we're really working with the ego state. And so it's more, again, than just hooking up the sensors and hitting go. We've got some work to do as therapists here. We talked about how old the state was from the beginning, and what we've done here with Alpha-Theta is we've actually integrated some of these things into our neurotherapy. No, I don't chant or drum or fast or dance, actually, when I do Alpha-Theta neurotherapy, but in chanting, in drumming, we're using repetitiveness. So that helps access the hypnagogic state. Fasting is a form of state change. Again, I don't use fasting in Alpha-Theta, but accessing a state change by driving the sympathetic nervous system by using a technique is kind of the same thing. Vision Quest, remember, we've talked about imagery, we've talked about visualization. There are elements of all of these things that help us shift the autonomic nervous system, which is what we're actually trying to do in our therapy room, perhaps a little more simply. So it's a multimodal modality. We join with a client. We've got some skills to teach, and among them are relaxation, meditation and mindfulness, creating a narrative or creating an image, creating a transformative image, client self-dialogue. All of those things are things that I'm going to join with my client if I'm going to have a successful implementation of Alpha Theta neurotherapy. I've got to facilitate this thing. So I've got to be present and I've got to know my client. I've got to be willing to use some creativity. Every single client is different, no matter whether it's an intervention for PTSD or addictions or optimal performance. So it's going to require some creativity on my part to help the client access what they need to create that transformative experience. I'm probably going to be working with them creating that visualization. I'm going to be doing some biofeedback. Now, biofeedback, we'll talk about biofeedback. Biofeedback, in some groups don't use it as much, others do. I maintain that biofeedback, or a form of psychophysiological self-regulation, is important for some of the key ingredients. And of course, we're going to be using neurofeedback. I put responsible, thoughtful, intentional practice here because we are working with individuals who are in a vulnerable state. They're accessing a vulnerable state. They're suggestive. We have a layer of ethical responsibility to make sure that we are not doing harm here and that we are supporting our clients for transformation and restoration. I've always thought, I had some training in hypnosis. I'm not certified. I did go through the 2 levels of training. And I always felt what a profound responsibility using hypnosis was. And I have brought that sense of profound responsibility into my Alpha Theta work. We're helping a client in a fragile space, and they're very delicate. So biofeedback, and I would say biofeedback slash psychophysiology regulation. This doesn't imply that you need to go out and purchase $1,000, $2,000, $10,000 system for biofeedback. What we're doing here is we're trying to teach clients skills that they can tangibly experience. We put EEG sensors on a client's head, and they sit there in front of our computer monitors and they watch bar graphs. They might watch cartoons or movies stop and go, but it's hard for clients often to develop some kind of felt sense of what's going on there. And so biofeedback has been that making that felt sense visible and real and tangible and concrete. In that way, it represents a building block toward Alpha Theta and sets our clients up for success. I could use a home training unit for this. I could use, a small handheld unit. I could use something as simple as a breath pacer and coaching if I needed to. But the key is that we have clients learn how to access those deeply relaxed states and set up the skill set, relaxing, clearing our mind, becoming aware of what's in our mind. All of those skills are in this biofeedback stage, and biofeedback's a nice way to accomplish it. Ultimately, we're helping this client downshift. So you see the old stick shift here. And, I tell people, if you just start with Alpha Theta neurotherapy and you do nothing else, it's kind of like driving along in 5th gear on the freeway, and all of a sudden you push in that clutch and you shift down to 1st gear. And if you've ever done that, there's quite a violent lurch that occurs. Your vehicles are usually not very happy about that. And it's a little harsh on your vehicle. It's a little harsh potentially on our client. And our client might not actually be able to access the depth of the state that we're working toward if we start too hard and too fast. And so using something like biofeedback and relaxation skills, all of those coaching skills are the things that help clients ease down into that state and demystify it for them. Um, Biofeedback can be heart rate variability or breath work. Yes, you can say breath work's not really biofeedback, but I think that anytime that you place a hand on a belly and you feel your own breath, you're doing biofeedback. SCMG biofeedback, temperature training. Temperature can be done with a piece of chocolate. So we can get really creative with this as we start to work with this. So within a session, what exactly does this look like? I'm going to show you a couple of different platforms, and I'm trying to be platform agnostic here. But my bottom line here is I want to show you this stuff has common ingredients when we start talking about neurofeedback. With neurofeedback, what we're typically trying to do is we're trying to encourage a state where, again, a person closes their eyes, they're producing lots of alpha, and as they become deeply relaxed, we want to reward them for producing more theta than alpha and give them some kind of signal when their alpha has receded and their theta has crossed over that. And so as a clinician, and this is an eyes closed state for my clients, so I'm not worried about what they're looking at or what movies they're watching. In fact, there's none of that. They're getting some sounds. And as a clinician, my job is to monitor what's happening with the client and make sure that they're getting the feedback when they access that state. For some systems, that's going to include possibly some adjustment of thresholds over time or mild tweaks to the filters. But what I'm typically looking at is I'm looking at training within the alpha band, somewhere between 8 to 12 or 8 to 11 hertz, and training within the theta band, somewhere between 4 and 8 hertz or 5 and 8 hertz. That varies on the text of the literature. And so you'll see 3 to 8 hertz. You will see 4 to 8 hertz. You'll see 5 to 8 hertz. You'll see 6 to 8 hertz. And there are various justifications to those nuances and filters. But at the end of the day, we're accessing a rhythm. Alpha is a rhythm. Theta is a rhythm. And when one rhythmic state recedes and the other becomes more dominant, that's an alpha. That's a crossover, looking toward the theta to become more dominant over the alpha. As a clinician, I'm going to watch the EEG. And in this particular example here, this individual is really starting to move into a theta state. I can see that their alpha peak frequency has started to recede. It's becoming less, and these people are producing a more dominant rhythm in about the 6, 7, 8 hertz range here. And I'm watching trend lines. So this is a trend. You saw one earlier. Alpha is turquoise in this state. In this particular implementation, theta is blue. And we can see, looking down at my trend, they've started out alpha dominant toward the beginning of the session, and then now theta is, crossing over. Some other common ingredients, I have filters that I'm watching. I have filters that I can set and define, and I can adjust thresholds, or I may have an automatic algorithm depending on my software. And I'm also having some indicator as to what this person is doing over time. So as theta becomes more dominant and becomes a trend, I've got some kind of clue that that's happening and it's maintaining. Usually it's an alpha over theta algorithm that a lot of systems are using. Now, what happens to the client? I've prepared them. We've done a lot of pre-therapy before even getting to the neurofeedback state. We've done biofeedback. I've taught them skills. We've had a lot of dialogue about intention and transformative messaging. And now I want to facilitate a deep relaxation session for the client that's safe and that allows the client to move into that state and work with it. And they also need to know if they're in that state. So why not just do meditation, Linda? Isn't that a lot easier? I don't have to have several $1,000s in equipment. Well, what I gain here is the ability to know if they're actually in that state. I can close my eyes and meditate all day and not move into that state. But if I can hear as I'm working on this, have some kind of signal, then I know how deep I'm going, and I know if I've gotten there or not. And for the client, When we're in the alpha state, many softwares will play a tone or some music. A very common one is a brook, so the sound of a brook babbling. And as people become more and more relaxed, the sound of the brook might become quieter. That's the alpha attenuating and going down, and then they might start to hear an ocean sound. And as theta becomes more dominant, that ocean sound might become more robust. They might get some other tones also, so they can just kind of know from moment to moment, are they doing theta? Are they doing alpha? They might get a tone that kind of helps gently wake them up if they go to sleep. Those are some of the feedback tones that people are getting. Now, this individual is in a very deep state of relaxation, and my sound is actually very, very soft. Remember what I said about things that had a strong emotional charge in the awake state having less of an emotional charge and vice versa? Well, interestingly enough, your client, even as soft as and subtle as these shifts are is able, when they get down into that deep state, to experience that and know it. And what's really neat is you unpack these sessions after they're done, and clients can tell you where they were. Here's another example of alpha theta neurotherapy. You're seeing some common things here. Once again, we're seeing the EEG. We're seeing some trends here. This is a long-term trend. You can see that at the beginning of the state, people had a lot of alpha. All of a sudden, that alpha dropped down. This little purple line is the crossover, and they've really done a nice job maintaining that crossover for a good sized period of time here. Again, we have some different ways of looking at alpha and theta. Again, I'm not rewarding theta. I'm rewarding the shift into a state. And the shift into the state is intentional and practiced, just like the shift out of the state and learning to maintain that level of sympathetic de escalation is intentional and practiced. Erase my drawings here. So you're kind of starting to see that there's a little bit more to this than just the algorithm that you might see packaged into your software. It's a good place to start, but if what we surround that algorithm with really makes the difference in terms of the quality and the success for your client. The other thing we've got to kind of ask here is, well, does every single piece of neurofeedback equipment and biofeedback equipment do this? And the answer is most major neurofeedback platforms have some accommodation for alpha theta neurotherapy. The exception would be if you have a platform that is only set up for Z score neurotherapy. So there are a few little platforms like that. You're not going to be doing alpha theta neurotherapy with Z scores. This is really about meeting the person where they are and training their brain uh, with its own feedback, not against a normative database. Uh, there are subtle differences in implementations amongst the systems, but they're all essentially trying to access that same pathway. I would say, just kind of as a caveat, and I give this to people doing neurofeedback all the time, in biofeedback, it's not just alpha theta neurotherapy. Be aware of claims that only this equipment work, or that equipment doesn't work, or that equipment doesn't do it right. Uh, Beware of secret sauce. I have a super secret patented approach, and we're just gonna put the electrodes on and press the buttons. You know, Valid interventions you can replicate, and so I invite people to read the methodology. I go to the papers all the time and, go skip down to the methods. Okay, what filters were they using? How did they do it? How many sessions did they do that? And the cool thing is that most of those papers are easily available online, which is exciting. You should be able to kind of know what's happening here. So it's absolutely worth reading the methodology. And some people might say, well, is home training equipment okay to use? Me personally, I don't use home training equipment for alpha theta neurotherapy. I have done distance alpha theta neurotherapy with people with whom I've worked very closely. That's a little different because I'm still there and I'm facilitating, and there are some very strict, tight guardrails around this. I'm aware of traumas, I'm aware of the client, and I'm aware of their needs, and the needs are pretty light, if you will. So I'd say use judgment there. I am going to stop because I actually overshot my time. So, Mitch,
Thank you, Linda. Yeah, thank you first. This is very good. There are a couple of things. It was asked, what are the frequencies that are used for alpha and then for theta?
yeah, so it really depends on the paper you use and the methodology. Anything from 3 to 8 hertz, 3 to 7 hertz, 4 to 8 hertz, 6 to 8 hertz, 5 to 8 hertz are for theta. Alpha could be anywhere from 8 to 12. I've also seen 8 to 13 utilized. And so there's a bit of variation there.
And relevant to what you were saying about home training, when you are dealing with folks with residual trauma, do you recommend that the person doing the neurofeedback, the alpha theta training, be a clinician and not just a technician because of the possibility of adverse reactions and so forth?
You should absolutely be a clinician and have training in trauma if you're working with PTSD and trauma. There's such a there's such an ability to wreak havoc with such a delicate client that I just can't recommend that a technician do that. Now, I will say this, as a coach, as a trainer, as an educator, as an optimal performer, there are probably individuals who are doing alpha theta to help athletes, to help executives who may not have the clinical background. However, they need some kind of training with trauma too, because that athlete may not disclose that trauma, may not even be aware of it. And so even technicians doing very limited work should have some kind of training with managing trauma and have somebody they can go to. So there should be an outlet.
And Linda, you really didn't say where you place the sensors.
Yes, you're right. I didn't because there's variability in that as well. So some studies worked with CZ, others PZ, others O1, and there's one system out there that does P3 and P4. Uh, Personally, I typically use PZ, and there are arguments to be utilized for all of those locations. I find PZ is a very easy place if someone's laying back on a chair, that sensor's out of the way. But there's also, we're working over a sensory integration area, and so there's also some mileage to be had based on where we're working. Uh, it's it drove me crazy why Peniston used O1 for a very long time, and I read obsessively about that. But from what I can start to determine, it really wasn't outlined in any of his papers. There's a pathway toward autobiographical memory that may be accessed in that area. So, and we're learning more every day. The more we start learning about networks, the more we're going to refine the where of this.
Okay, I will refer everybody, if you haven't looked at the chat, kind of check it out because if you want to hear more about this, you can visit the NRBS podcast that Saul Rosenthal uh, runs, and there is a link. So if you want to hear more about this, certainly check out the podcast. And it's 12:58. Unless anybody here, why not just train alpha down and theta up with the eyes open? Why all of the woo-woo?
That's fair. With eyes open, we're accessing a more conscious state. We're accessing a conscious awareness, and we really have to get out of that frontal lobe. So closing the eyes shuts down our visual processing. It takes us out of it's one way of taking us out of the frontal lobe. When we're using conscious judgment, we are not getting into that state. And so, eyes open, alpha up training, theta up training, or alpha down training, theta up training, probably not getting us to the same place. It really helps us to have that signal when one has receded and simultaneously the other has crossed over. But in fairness, I will also say that Jay Gunkelman has said, "You know what? We never had to deal with the alpha theta, we just trained alpha up." I would respectfully argue that it was probably a slightly different state. It was helpful, but probably a slightly different state.
All right. Everybody's writing here, thank you, and then we all
Oh.
say thank you.
Guys,
Thank you very much,
thanks for
and
having me.
thank everybody for being here. We appreciate you showing up. So have a good week, folks. Thanks again,
Take care,
Linda.
you guys.